Welcome to the Curvafix Masterclass, featuring an expert panel of key thought leaders discussing increasing case experience using the novel Curvafix IM implant for pelvic fracture fixation. My name is Dave Briggs, and it's my pleasure to open tonight's session. We have a truly exceptional group of outstanding speakers who will present U.S. clinical experience with the only intramedullary device to follow natural bone shape and fill the space within curved bones, such as the pelvis, to treat pelvic fractures and the challenges it may help overcome for both high impact trauma and fragility fractures of the pelvis. Before we begin, one reminder, be sure to make frequent use of the Q&A button at the bottom of your screen. Thank you for joining us this evening, and it is my pleasure to introduce the moderator for tonight's symposium, Dr. Samir Mehta. Dr. Mehta is the Chief of the Division of Orthopedic Trauma and Fracture Care, Medical Director for Orthopedic Clinical Research, and Associate Professor of Orthopedic Surgery at the Hospital of the University of Pennsylvania. Dr. Mehta developed and serves as co-director of the Penn Orthoplastic Limb Salvage Center. He holds several local, national, and international leadership positions in orthopedic trauma, helping define goals of care for the next generation of surgeons and volunteers in developing nations, providing education and patient care. Dr. Mehta, the floor is yours.
Thanks, David, for that very kind introduction, and thanks to all of our attendees tonight. We have an expert panel of highly experienced orthopedic surgeons joining us this evening, including Mike Tilley, Brett Christ, James Shaw, and Professor Paul Romans. During tonight's masterclass, we'll discuss the growing use of this novel Curvafix intramedullary implant to treat pelvic fractures and the challenges that it may help us overcome for both high energy, high impact trauma, and also fragility fractures of the pelvic ring. Our expert panel tonight will share their ongoing and expanding experience using this novel implant. In addition, we'll hear more about the increasing need to address fragility fractures of the pelvis and surgical treatment options that this particular implant allows us to obtain. I'd like to introduce the faculty that'll be joining us tonight. Mike Tilley is an orthopedic surgeon and trauma and hip reconstruction specialist at the Stormont Vale Hospital in Topeka, Kansas. He will be speaking this evening about using the Curvafix implant for anterior and posterior fixation for insufficiency-based fractures and non-unions. Brett Christ is the Director of Orthopedic Trauma Service and Director of the Orthopedic Trauma Fellowship and the Vice Chair of Business Development at the University of Missouri. He will present one of his fragility fracture cases where he used the Curvafix intramedullary implant to repair a sacral non-union around an existing lumbosacral hardware fixation. James Shaw is an assistant professor of orthopedic trauma at the University of Texas McGovern Medical Center in Houston, where he also earned his medical degree. He will present two cases of percutaneous fixation of the posterior pelvic ring in dysmorphic patients. And lastly, we have my friend, Professor Paul Romans, a retired head and Department of Orthopedics and Traumatology at the University of Medical Center of the Johannes Gutenberg University of Mainz, Germany. Professor Romans is currently an AO Trauma International board member and chairperson of the AO Trauma Research Commission. He's authored over 675 original papers, including a comprehensive classification for fragility fractures of the pelvic ring, along with recommendations for treatment. He also co-edited the book on fragility fractures of the pelvis, which was published in 2017. He will present on fragility fractures of the pelvis as an underappreciated and growing problem of the pelvic ring. A few housekeeping notes. We'll be keeping track of your questions. The panel will actually look forward to answering these questions during our live Q&A session after the case presentations are done. Please let us know your questions if it's for a particular surgeon, otherwise we'll throw it out to the group. In addition, Steve Dimmer, Curvafix's CEO, will be joining the panel for any questions that you may have about the company. To get things going, I'd like to open with a short presentation on pelvic ring fixation in the case of a spondylopelvic dissociation. So this case is a case using a Curvafix implant in the case of a patient who's had a spondylopelvic dissociation. This is a 65-year-old female who had a fall. She has known diffuse large B cell lymphoma and has known multiple lytic lesions throughout her body, including her pelvic ring. Prior to her fall, she was walking independently. She had limited to no pain and was able to live independently at home. After her fall, she was unable to tolerate any weight bearing for 3 days. She attempted modified weight bearing with a walker. She attempted bed rest, but really was actually, for her husband and her, getting worse, not better. And this was having a dramatic impact on her function. She ultimately obtained imaging, including this inlet and outlet view. More telling is her CAT scan, and the CAT scan shows uh, fractures of her sacrum bilaterally. The axial CAT scan shows her tunnels coming into picture there, and you can see the multiple lytic lesions throughout her posterior pelvic ring. Understandably, this is quite painful for her. Her sagittal view shows a deformity that's concerning, obviously, as you'll see it come into play here, for possible neurologic involvement. Fortunately for her, her neurologic exam, at least at this point, was normal. Here are some static images of both her axial CT showing the involvement of the upper sacral segment and the tunnels, as well as the lytic lesions throughout the pelvic ring. And then here's that static image of that sagittal view showing the deformity of the posterior pelvic ring, particularly the risk of impingement on the sacral roots. So we had a fairly lengthy conversation with her about her treatment options. Obviously, she's undergoing chemotherapy and radiation therapy for her existing cancer. She also, has a quality of life that she wants to maintain. It was unclear what her prognosis was from her oncologist. It was a bit mixed. And so that also affected our decision making. She's also very frail. She's a thin woman, and her nutrition is not optimal for obvious reasons. As a result, we chose to go with percutaneous fixation of the posterior pelvic ring. One of her goals was to be as independent as possible and not to be limited towards this part of her life. Given the nature of her fracture, we wanted to give her good posterior ring stability so that there would be a limited risk of neurologic injury. You'll see here on the inlet view that we have a nice view here. We can see the anterior aspect of the sacrum. Here you can see insertion of the entry reamer in the upper sacral segment. The starting point does not have to be quote unquote perfect because of the curved nature of the implant. We can find a starting point that is optimal from a bone perspective because of her metastatic disease. We didn't have enough, we didn't have the same kind of landing spots that we typically do. You'll see here that the first wire has already been passed across the upper sacral segment, and now I'm passing my S2 wire. The one thing I would caution you is because of the size of the implant, it's hard to pass the screw and then be able to visualize the second sacral segment, particularly on your inlet view. And so it's really important that you pass the wires before passing the actual screw so that you can visualize this on the various imaging that you'll be getting. Here you can see her sacral tunnels and navigating that curved tip wire around the sacral tunnels. Despite the quality of her bone, we were able to safely navigate this wire across the posterior pelvic ring. You'll see here that the wire is aimed posteriorly away from the anterior sacrum so it doesn't breach. And then the wire is passed across to the far side, again, avoiding the S1 tunnel that you can see there, and then feeding the wire across the opposite SI joint. Here you can see the first screw has already been passed, and I'm reaming for my second screw. And this is ultimately what the construct looks like posteriorly with the two screws, one in the S1 segment, one in the S2. You can see that second screw bending around the left S1 tunnel. You can also see the curved nature of the implant here and the volume that the implants utilize in the posterior pelvic ring. Here's an axial CT that shows the safe passage of the implants with no impingement on the upper sacral segment nerve roots. And you'll see that the implant is able to curve through S2. You'll see on these static images, the passage of the implant from left to right. and safe passage on both the coronals, on the axials as well as the sagittal. At 4 weeks post-operatively, she's recovering at home and doing well. She walks independently already, and she reports improvement in her pain. She is, I made her weight bear as tolerated. I have, with this implant, because of its size and its positioning, I was able to allow her to be immediate weight bearing. At 4 months post-op, she's still recovering at home. She does have some aches to her low back and pelvis and lateral hips. Some of this is due to her metastatic lesions. It does cause her some frustration, but she's not taking any pain medication. She does walk independently and is continuing to do physical therapy, and she feels an improvement in strength, and she's continuing with her treatment for her non-Hodgkin's lymphoma. Thanks for your time, and we're going to go on to our next presentation. Now, I'd like to hand it over to Brett, one of our 30 surgeons who's now using the Curvafix implant in the United States.
Hello, I'm Brett Christ. I'm a professor at the University of Missouri in Columbia, Missouri, and I'm an orthopedic trauma surgeon. And I've been here for about 18 years. And the title of my case is Maneuverability Makes It Work. And so my patient was a 69-year-old female who fell onto her right side while kind of leaning up against an automated door. She fell 3 weeks prior. And when she presented to clinic, she was having pain with weight bearing in her right groin, and occasionally using a assisted device prior to her fall. She does have some pretty significant medical comorbidities, including non-insulin dependent diabetes. She is obese. She has multiple sclerosis and hypertension. And then, as you can see on her AP image, she has had a previous lumbosacral fusion, but has also had 2 total knees. Those have been working fine. On physical exam, she was tender to palpation over her pubic ramus and had limited internal external rotation of her hip, secondary to pain. And at presentation, she did not have any pain posteriorly. So these are different views that we have. They didn't really have a great inlet view initially, and so we had to repeat that. But these are her AP pelvis and outlet views. And you can see there's really not significant displacement of her pubic and ischial rami fractures. And this is her inlet view, showing no significant or really any rotational deformity. And it's really not evident that there's any posterior ring injury on plain imaging. And so she ended up getting a CT scan in the ER, which shows her pedicle screws in her sacrum to be intact, no obvious posterior ring injury. You can see her rami fractures are not very complicated. And interestingly enough, she must have had some either injury beforehand, or she already started trying to generate callus at 3 weeks in her ischial ramus fracture, which I would say would be pretty unique for somebody in her age range. These are coronal reconstructions, as you can see here, and it just verifies that there's no significant deformity associated with her rami fractures. Here are sagittal plane reconstructions. She didn't really have any sacral dysmorphism or any irregularity of her sacral corridors except for her indwelling hardware. And this is just inlet view 3D reconstruction showing that her overall alignment of her pelvis looked good at that standpoint. So the plan was non-operative management. She was weight bearing as tolerated, working with physical therapy, and planning to follow up in 1 month with referral to our bone health team for evaluation and management of osteoporosis. She eventually she worked with physical therapy while she was in the hospital and was discharged to a skilled nursing facility. She came back a month later, so this is now about 7 weeks from injury, and she saw a colleague of mine and had no x-rays at that visit for some reason. She had been discharged from a skilled facility a week prior. She was still having 8 out of 10 groin pain, ambulating with a walker. She did have less groin pain than on her initial exam, and 4 out of 5 hip flexion, but it was painful. and was going to transition to outpatient physical therapy and follow up 1 month later. She did end up getting evaluated for her bone health, and these are some pertinent labs. And she was scheduled to get a DEXA scan, but she did not do that. But she had some chronic elevation of inflammatory markers. Her vitamin D level was normal. Her thyroid level was normal. She did have an elevated parathyroid hormone level, and prealbumin was okay, indicating that her nutritional status was okay, despite it doesn't matter if you're obese or not, you can have abnormal protein levels. And for some reason, she did not follow through with her DEXA scan. This is her 1 month later. So this is at the 11-week mark. And so you can see that she's trying to generate some callus on both rami fractures. There's no change posteriorly that I could tell on plain imaging, but there's no progressive deformity, rotational deformity, or sagittal plane deformity. So then she gets hospitalized for heart failure, which is obviously no good. And she works with the cardiac team and is doing some cardiac rehab. And she could presents at 5 months. She has significant limitation of activities of daily living due to her groin pain. She's walker and wheelchair dependent. She actually said her 90-year-old mother is more active than she was at the time, and that frustrated her. She started having posterior pain, but was still having more anterior pelvic pain than posterior pain, and this is what was limiting her daily function. And on exam, she did have pain with hip rotation, and she was tender palpation over her right sacrum at that visit. And you can see that she is trying to generate callus on her AP imaging. And so in talking with her about treatment options and with how far she's out from her original injury and how debilitating this injury has become, she had delayed union of her rami fractures. She started having posterior pelvic pain, and her pain was still prolonged and limiting her daily function. And she actually had less function than she previously did. And so what are her specific risk factors for pelvic non-union? I would say her lumbosacral fusion is creating significant rigidity in her posterior pelvis. And so she will see more motion at the front of her pelvis because her posterior pelvic ring and lumbar spine is not really moving very much. And I've seen more geriatric or elderly patients get sacral insufficiency fractures related to lumbosacral fusions. At least that's I don't think that's only my opinion, but it just is so rigid back there. And then as their bone quality decreases, their risk of insufficiency or worsening fractures with falls, like more complex fractures, at least I've personally seen over the last kind of 5 to 10 years than previously. She also has had a previous gastric bypass, which has been shown to significantly increase the risk of osteoporosis. Basically, within 4 years of getting a gastric bypass, the incidence of distal radius fractures goes up significantly, and that's thought to be secondary to poor bone quality. And then she also has a family history of osteoporosis. So her problem list is her right pubic and ischial delayed union, right sacral pain. She's had her lumbosacral fusion. Obesity is supposed to be protective for osteoporosis, but it makes surgery harder, both imaging as well as access. And then her lumbosacral fusion limits the real estate into the first sacral corridor. And I thought she had a big enough second sacral corridor, but I really feel like the rigidity problem is in the first sacral segment. And so I felt like I needed to stabilize that sacral segment to make her pain improve, because if I just go with the level below it, she could potentially create a stress fracture between her lumbosacral fusion and whatever implant I use in the second sacral segment. So I thought it was important to be able to fix the first sacral segment. So these are intraoperative images. And this is, I thought, really demonstrated kind of the maneuverability or flexibility or the benefits of Curvafix, because I did not think I could get a standard cannulated screw device across the first sacral segment. So this is the first attempt at getting the guide wire across to the opposite side, and I felt like I wanted to go into the opposite ilium, so iliac transsacral fixation. And that was the inlet view. Here's the outlet view, and just different sequences of trying to get readjusting the wire and getting it around through the safe corridor. And I think that's a significant benefit of this technique, is even in poor bone quality, you can tell when you're getting to the periphery of the bone or the safety of the corridor. And so this is getting it across, and you can see here with I had the wire across further, but couldn't really get the reamer across the pathway because of the pedicle screws. And so attempt number 2, I decided to go actually try to go above it. And these are just more images showing maneuvering the guide rod above and then below. Again, I felt like I got more posterior, so there would be more room. And so there's the final positioning of the wire. And then just more imaging showing getting it to the opposite side in preparation for placing the Curvafix device. And then the device going across. And I thought these were pretty neat images showing how it's making its way across and changing position or maneuvering its way across the pathway and getting to where it needs to go, getting past the lumbosacral fixation and getting finally seated and showing that it's down. And then finished by placing a retrograde ramus screw, which her corridor was too small for the currently available Curvafix. And so just a 4.5 millimeter cortical screw. And so she was made weight bearing as tolerated, resumed her anticoagulation that she was started on for her heart issues. And then plan was to return to the bone health team and do physical therapy. And these are her post-operative images, including Judet views and the standard inlet and outlet views. I was concerned due to her bone quality about implants starting to back out at 3 weeks, but these are her 3-week images showing that there hasn't been any back out. And she was doing better pain-wise. She'd been doing actually significantly better from when she was in the hospital. And then she presented, it was actually a week ago, to the ER after a fall. And she had an episode where she passed out. She was evaluated, and her main complaint was her right shoulder, her left total knee, but no increased pelvic pain. And so I just actually saw her this week. And I thought on her images, again, clinically, her shoulder was the thing that was bothering her. She really had really minimal tenderness over her left SI joint, but these are her images. I thought she was increasing her callus formation on her rami fractures. And she feels like her main issue is getting her balance and these episodes of passing out kind of figured out. She didn't have any groin pain on range of motion, which was a significant improvement from prior to surgery. She was still using a walker. And I felt on exam that she really had a rotator cuff injury, which she had previous rotator cuff surgery. And she also had glenohumeral arthritis, and I didn't include those images. But the plan for her pelvis, so I'm going to have her see one of my shoulder partners, but her plan for her pelvis is to follow up in 3 months with new x-rays. But I thought from her pelvis, her pain had significantly improved and she was happy with it. So in summary, geriatric pelvic fractures aren't all non-operative management. There are definitely, we have a protocol if patients can't mobilize with therapy after three attempts that we consider acute fixation, but she had been doing okay prior to her continued difficulty healing and progressive pain and decreased function. Fixation does improve pain and function, and this has been demonstrated in the literature, especially outside of the US. And having a maneuverable implant made this surgery possible. I really thought getting fixation in the first sacral corridor was important to avoid an interprosthetic fracture, especially an insufficiency fracture down the road. Thank you.
So I'm Mike Tilley. I'm a orthopedic surgeon in Topeka, Kansas, working through the Stormont Vale health system. I did my orthopedic residency at the University of Kansas and my trauma fellowship at the University of Minnesota. And I have the pleasure today of talking to you about treating osteoporotic related insufficiency fracture non-unions in both the anterior and posterior aspect of the pelvis with a Curvafix device. What we'll get into with this is just a case presentation and demonstration of some of the difficulties in these osteofixation pathways and these osteoporotic fractures and fracture non-unions, typically because there's some deformity involved with them and also some issues with bone quality. To start, this is a 57-year-old female who had a fall at home in July of 2021. She presented to me nearly a year later in June of 20 or in late spring of 22 with this. She had seen several other providers. I think she'd seen 3 other orthopedic surgeons in different parts of the state before getting referred to me for this issue. When she was first seen, this was thought to be a stable insufficiency fractures of both the posterior and anterior aspects of the pelvis, and she was told that this would heal uneventfully and she didn't need any type of surgical treatment with this. Her pre-injury status is fairly typical for these patients that I'm seeing with this, where she was getting around without any assistive devices whatsoever. She's relatively young, but she's also osteoporotic. She has rheumatoid arthritis. She's a touch malnourished when we checked her labs for osteoporosis workup with this. And she also smokes at least, she's cut down to a pack a day from who knows what it was before that. So she's a little bit younger than a typical patient I'm seeing with this, but, kind of has some other factors that maybe throw her into a more advanced age. Other things that play a part in this is you can see she has some a degenerative scoli with her lower lumbar spine, and she was scheduled to have a lumbar spine procedure a month after she fell, and that was canceled secondary to her pelvic injury, and she's yet to have that done. So these are the films that she presented to me with. You can see that she has a fairly obvious fracture of the inferior and the root of the superior ramus in the front of the pelvis, and certainly something going on with that SI joint in the back, possible subluxation and fracture involving her posterior pelvis on that right side with it. She's had several CT scans and radiographs throughout the several months leading up to her presenting to me. And this is just another look at inlet and outlet films that re-demonstrate this. You also have some Jude films where you can get some ideas on the bony reabsorption that she had around that fracture that extended into the anterior wall through the root of the superior ramus on this view as well. This is her CT scan, which shows the injury on the right side and also an injury on the left side of the pelvis as well. The image on the right is getting into the anterior wall superior root fracture non-union, where you can see that she has a significant amount of bony reabsorption with it. There was some concern prior to her seeing me of this may be a pathologic fracture secondary to tumor. Her workup for that was negative, and this was an isolated lesion. And in my review of this looks more like bony reabsorption around a chronic non-union site more than any type of tumor in this. And with any bilateral sacral fractures, you always want to look at a lateral, be it on the sagittal recons on the CT scan or a lateral sacral view. And with her, you can see that she has kyphotic deformity through the probably the S3 segment of her pelvis. You can see that 4-5 slip and that degenerative disc that she has above this. Those are all things to keep in mind because it's going to affect your ability to image her with fluoroscopy within the OR. Also, these people tend to have fairly poor bone quality, and their imaging can be somewhat difficult in these cases. This is some sagittal cuts to that superior ramus fracture, and you see the bony resorption through that area as well. One of the things that's I think extremely important to these people is to get their nutrition status back up to on par. You want to look at their albumin, make sure that it's getting up above 3.4 is typically kind of what I'm looking at for it. It's not necessarily a reason not to operate on these people, but you want to try to optimize both their nutritional status and their osteoporotic treatment, whether that's getting them on some anabolic agents and getting their vitamin D and everything corrected. Can either do that through a bone health clinic or endocrinology is the most typical way that those are done, and that's a very important part of treating these patients overall. Will help your success when you do have to operate on these. This is some intraoperative pictures of this. One thing to know is the exchange tube that's in the posterior aspect of this. So I started where I knew that it would be the easiest to get a path across with the starting point for these posterior screws. Typically, I'm going to start more inferior or more posterior on the lateral wall of the ilium than what I would for a traditional straight screw. That way I can start that pitch and help kind of build the curve into the implant, because you don't want this implant to be put in straight across. You do want a curve to it so you can take advantage of its ability to resist the moment of rotation. That's about the pelvis there in the back. This is a view of the putting the implant in the front. I always try to get my wires and the exchange tube in the back before I start doing anything in the front. That way you're not blocked in any of your imaging by an implant already being there. Typically, when I'm starting these for the front, I'll start them typically a little bit more superior and posterior than what I would typically start, because you have to get the first 3 centimeters in where it's going to be straight, and then you want to try to get some curve built on this. This is a situation where a smaller implant would be of some advantage, as you'll see on some later cuts, where this is a pretty tight fit for this. I measured the canal diameter through the superior ramus on the intact anterior aspect of this fracture at approximately 9.5 to 9.7 millimeters preoperatively, and this is a 9.3 millimeter implant, so it doesn't give you a whole lot of room. And I was just told earlier today that the smaller version of this implant is FDA approved at this point in time. This is what her final construct looked like, where you can see that you have a nice curve built into the back, and this curve can be not only in the cephalad caudad direction, but also in the anterior posterior direction. And you see that there is some non-linear appearance to the screw through the anterior column. The only note I would make on this is it would be nice to take and curve the wire towards the midline on this, as I'll demonstrate in a later slide. The threads of this do do come out in the front, which is fairly typical when you're putting in a straight implant. At least in my hands, I see that fairly commonly, where you'll come out right beside the pubic tubercle with this, especially in these smaller corridors with this. This is her post-op imaging with it, and you can see the implants in place on the AP, and also the inlet outlet views and a Jude view where you can see it crossing across there, providing some stability to it. I am still CTing these mostly for my own education, to ensure that I am indeed putting these implants where I intend for them to go, and I'm not being fooled on any of my two-dimensional imaging intraoperatively with it. Unfortunately, we're not very good at getting metal subtraction imaging at my institution on these, so there's usually quite a bit of scatter and artifact around the implants with these, but you can see the screw crossing in the back there, and then also crossing that non-union site in the front and getting down where it's filling that canal in the front. Like I said before, this is a fairly tight fit in there, so you are getting good intermedullary fill and contact with that, much like putting an intermedullary nail in an isthmic type fracture in a long bone. And you can see the screws where they do exit out here in the front, but generally that's not uncommon for me to see when I put in traditional straight screws, but curving the tip of that wire towards the midline may help with that in the future. This is her follow-up at approximately 2 to 3 weeks out. There's no obvious implant failure. At this point in time, she's still on her walker, but she states that her pain is much better with it, and she is able to, prior to her surgery, her husband would say that she could walk from the kitchen to the living room, and that's about it. She could not stand to make supper, and was very limited in her ability to be upright with this, and that has improved with fixation, these fractures. This is approximately 6 to 8 weeks out, and again, she's maintaining her implant placement. There's no obvious loosening. There's no obvious failure. She's beginning to progress off her walker. She's still having a significant amount of pain. My suspicion this is coming a lot from her lumbar spine. As I said before, she was scheduled for a lumbar spine surgery before this occurred. And I think that she's still symptomatic from that 4-5 slip, and likely some stenosis in that aspect, which I think is playing a part in her being somewhat slow to progress. In my experience, patients that have just this problem, non-associated lumbar spine issue with it, the vast majority of these that have been taken care of are significantly better and off their assisted devices within a few weeks after their operation, and most of them will say they're significantly more comfortable nearly immediately afterwards. So I think that providing some fixation, some stability in these insufficiency fracture non-unions can significantly help people mobilize and return to a better quality of life with this. And I think this is a implant that allows us to more safely traverse some of these difficult osteofixation pathways, particularly when there's a significant amount of deformity with it. That kind of covers what I have for you guys. Thank you, guys.
Okay, thank you, Dr. Christ. Good evening. My name is James Shaw. I'm an orthopedic trauma surgeon in Houston, Texas. And today I'll be highlighting 2 cases utilizing the Curvafix implant for percutaneous fixation of posterior pelvic ring injuries in dysmorphic patients. So first case example is a 59-year-old male who fell 20 feet from scaffolding. He was polytraumatized. He had a subdural hemorrhage, multiple rib fractures, an open left humerus fracture and this pelvic ring injury seen on the right. Patient was neurovascularly intact on presentation. From the AP pelvis, looking at it, you can see no appreciable injury in the anterior ring, but looking on the right side posteriorly, possibly an injury. This is the open segmental humerus fracture that the patient also sustained. Axial CT scan shows that the patient has a complete right-sided sacral fracture with traversing fracture lines as highlighted by these arrows to the contralateral side. There's also a right-sided iliac crescent fracture, no appreciable injury in the front of the pelvis. And again, this patient has sacral dysmorphism. Correlating this with the 3D surface rendered image, again, the right-sided crescent injury and the oblique traversing sacral fracture. So a little bit unusual of a posterior pelvic ring injury, not that commonly seen. So to briefly look back at the literature, sacral dysmorphism occurs in approximately 40% of patients. The dysmorphic sacrum has an acute and upsloping sacral ala, which is oblique in nature, and this misshapen osteology limits your available osseous fixation pathways for your implants and makes transsacral transiliac fixation with a straight implant nearly impossible. So again, looking back at our patient, this patient's dysmorphism is not that dramatic. As you can see, there is an osseous fixation pathway for a straight implant, but probably not a very large one. Moving more caudally, there's potentially more space for, again, a straight implant, but your start and end points need to be precise, otherwise you risk extruding anteriorly or intruding into the sacral neuroforamen. So really, this patient has ample osteology for iliosacral fixation, should you choose. And so we indicated this patient for surgery and thought that this patient would be an excellent candidate for the Curvafix implant. So here we took the patient to the OR. We positioned them supine with a midline lumbosacral bump on an OSI flat Jackson. Here we are localizing our start point with a 2.0 millimeter Steinman pin, followed by our entry reamer, our introducer with our steerable guide rod, judiciously using biplanar fluoroscopy to navigate our steerable guide rod in the osseous corridor to the contralateral side. Here we're measuring and then over-reaming. At this point, we elected to go to the second sacral segment prior to application of the Curvafix implant. And again, this is to assist us in our visualization of the second sacral segment and not obscure it from the larger Curvafix implant. So we elected to apply a 7.0 millimeter straight, fully threaded cannulated screw in the second sacral segment, and the Curvafix in the upper sacral segment. Final AP inlet and outlet fluoroscopy. So we routinely use postoperative CT scan to assess implant placement, safety, and reduction. And here you can see the Curvafix is safe in the upper sacral segment, as well as the straight screw is safe in the second sacral segment. And then postoperative AP inlet and outlet films. In a different setting, we elected to perform ORIF of the patient's left humerus as well. Our second case highlighting the Curvafix is a 32-year-old female who was a pedestrian struck by an automobile. She was also polytraumatized with a liver laceration, multiple rib fractures, and this pelvic ring injury. She was neurovascularly intact on presentation, and she also sustained a right clavicle fracture. This was her right distal clavicle fracture. And representative AP inlet and outlet films of her sacral injury. Preoperative CT scan shows that this patient has sacral dysmorphism. She has a complete right-sided zone 2 sacral fracture. and a right-sided high ramus and parasymphyseal superior ramus fracture, as well as an inferior ramus fracture. Representative 3D surface rendered imaging, again, complete right-sided sacral fracture and segmental right superior ramus fracture. So again, this patient's dysmorphism is more acute, and really there's no available osseous fixation pathway for a straight implant, at least in the upper sacral segment. But this patient does have ample room for iliosacral placement. So we, again, indicated this patient for surgery and thought that she would make a good patient candidate for a Curvafix. In the interest of time, just the final fluoroscopy, highlighting the inlet and outlet films of the Curvafix implant in the upper sacral segment, avoiding the sacral neuroforamens and staying within the osseous limits. And we also elected to apply a retrograde superior ramus screw. Final postoperative film and postoperative CT scan, again, demonstrating safe placement of the Curvafix implant. We also elected to fix her distal clavicle fracture to allow the patient to utilize the right upper extremity for transfers and mobilization. This is her 10-week follow-up. The patient was fully weight-bearing at the time with minimal pain to her pelvis. So these are two great case examples highlighting the ability for the steerable guide rod and the Curvafix implant to navigate the osseous anatomy of the upper sacral segment in dysmorphic patients. And with that, I'll conclude. Thank you.
Good evening, dear colleagues. My name is Paul Romans. I am the former director of the Department of Orthopedics and Traumatology at University Medical Center of the Johannes Gutenberg University in Mainz, which is situated in the Midwest of Germany. Before we focus on fragility fractures, I would like to get you acquainted with the definition of the World Health Organization. A fragility fracture is a fracture that is caused by an injury that would be insufficient to fracture normal bone, the result of reduced compressive and/or torsional strength of bone. So when we talk about fragility fractures, that includes osteoporotic fractures, insufficiency fractures, and so-called geriatric fractures. When we focus on this, we have to think about the aging population in our industrialized countries. You see here the graphic of the median age of populations in 2020s in large countries of the world. And you see that Japan and Germany have the oldest populations, which is 48.4 and 45.7 years of age. That means for Japan, that has 100 million inhabitants, that 50 million of their population are older than 48.4 years. And the same for Germany. About 45 million people are older than 45.7 years. That brings us to new problems because we are facing two diseases and comorbidities of the aging population. Here you see a publication out of 2014 from the United States. The authors have looked at the discharge diagnosis of all Medicare patients, that means 65 years and older, in the United States between 1993 and 2010. So it's an 18-year period. There were about 250 million discharges from hospital in this time. In the traditional hip fractures, so the pertrochanteric and femoral neck fractures, count for about 3.5 million. The pelvic fractures only for 500,000, and the acetabular fractures for less than 100,000. But if we look at the incidence of these fractures over time, then you see that the traditional geriatric fractures have a peak in 1996 and then continuously decline to have a decrease of 25% in 2010. But the opposite is true for closed pelvic fractures. You see a steady increase over time and also about 25% in these 18 years. Certainly, the absolute numbers are still very different. We are talking about 500,000 classical geriatric fractures on the hip and only 100,000 pelvic fractures in this period of time. But the increase of incidence of the pelvic fractures is very clear. And here we see some more recent publications out of the European Union, which show the similar trends. You see here a study of Finland from 2015, which shows the age-specific incidence, and you see for women and for men, you see a steep increase, and it continues to increase until 2030 of all categories, especially patients above 80 years of age. The same is true in Germany, where we have the following publication on the epidemiology of pelvic fractures, and you see the title, Considerably High Incident Rates Among Older People. And one of the graphics in this publication shows a steep increase of the incidence of pelvic fractures in all patients of 80 and above, even of 75 and above, be it women or men. This is a graphic of the German pelvic trauma registry. There are 3 different periods in this registry, 91 to 93, 98 to 2002, and 2004 to 2010. And here you see the incidence of the pelvic fractures depending on the age and on the sex. And you see in the first period, 91 to 93, that the majority of the pelvic fractures occur in young men, excuse me. And in 2004 to 2010, there is a clear shift towards older women. So in a period of 20 years, we face a totally different patient population. A more recent publication in 2021 looks back at the incidence and mortality risk after pelvic fractures in Austria. And also here, there is a clear increase in the incidence of pelvic fractures in the elderly population, with a greater increase in men over time. The same is true for Switzerland. Another publication from the European Union and outside current results corroborate the trend of increasing frequency of fragility fractures in the aging society. The demographic shift has a direct impact on the fracture pattern, with a disproportionate increase in partially stable compression fractures. A publication of 2016 from the United States shows that there is an increase in incidence in pelvic fractures. Here we look at all pelvic fractures, not only the elderly patients. But what is striking in this publication is that mortality declined in this population with pelvic fractures from 4.2 to 2.8% in this 20-year period of time, and that this was depending on surgical fixation. So when a patient was treated surgically, the mortality decreased. A last study that I want to show you, because Belgium is my native country. Also here we see an increasing incidence of pelvic and acetabular fractures with the majority of these fractures occurring in the older people. So this is not only a trend, it's already a reality that in most of our countries, we are facing a clear and steep increase of the incidence of pelvic fractures in the elderly, especially in women. That leads us to the question, what are the differences between pelvic lesions in adults and in the elderly? We can say that in adults, we are facing high energy trauma. And in the elderly, we are facing low energy trauma. So falls at home from a standing position as a typical example. The most striking difference in the patients themselves is the strong bone in the adults and the strong cancellous bone, and the weak and very weak cortical and cancellous bone in the elderly population. So that gives a different morphology to these fractures. I will come back to that later. And even if the patient is treated conservatively, there may be an increase of instability over time. Here you see a study that has been done in the AO Research Institute in Davos with one of my collaborators. We looked at 92 Europeans, and here you see three-dimensional models of the sacrum that were clustered in two groups. In one group with patients that had a higher bone mineral density in L5, and one group that had a lower bone mineral density in L5. This was measured in Hounsfeld units. In the group with a higher bone mineral density, we only see small islands here in yellow we call that sacral voids. These are areas where no bone is present anymore. The intensity here is equal to that of water. If we look in the group with a lower bone mineral density, we discover large areas of alar voids in the sacral ala left and right, some islands in the middle of the sacrum, sometimes even that connection between the alar voids on the left and the right side. And that explains the typical morphology of the sacral fractures in the patients with fragility fractures of the pelvis. You see unilateral vertical fractures in the sacral ala, so lateral to the neuroforamina. This can be unilateral, it can be bilateral, and there can be an incomplete or a complete transition between the vertical fractures. And you see here in the last drawing, this is a H-type injury. In the adults, we call that spinopelvic dissociation. But the clinic that we see here in the older population with H-type injuries is totally different than that in the adults. Two examples, you see here an 83-year-old female. 3 months after the onset of complaints, for the first time a CT scan and conventional X-rays were taken. In the conventional X-ray, you see a huge displacement on the left pubic rami. If you see the CT scan, this is a transverse, a coronal, and an oblique reconstruction. Then you see these complete fractures in the sacral ala on both sides. Here, the internal rotation of the left hemipelvis and the displacement near to the symphysis pubis in the front. So that's a highly unstable lesion of an 83-year-old patient. Another patient is 81-year-old, recurrent falls at home, pain since months that were, the lesions were treated conservatively. Patient was not seen by any doctor. Then she came to us and we took CT scan. You see the reconstructions here, severely displaced fracture on the pubis on the left, 2 complete fractures in the sacral ala, left and right, and you see these alar voids very nicely here. A horizontal fracture between S1 and S2. And here in the reconstruction, you see the combination of the lesions in one plane. Also here, we can say this is a highly unstable lesion, but the patient here is still able to walk independently with crutches, which is certainly, if you have this type of injury in the adult, there would be an impossibility to move. These were reasons for us to look back at 245 patients in our hospital that suffered a fragility fracture of the pelvis. And we were able to recognize different categories of instability and developed, therefore, a comprehensive classification combined with recommendations for surgical treatment. And you see here the first criterion of our classification was the degree of instability based on pictures of conventional X-rays and CT. The second criterion was the localization of the fracture in the posterior pelvic ring, because there, if you decide a surgical treatment, it depends on the localization of the lesion, where you will and how you will stabilize this fracture. We could distinguish 4 different categories: an FFP, that stands for fragility fracture of the pelvis. The first category is an isolated anterior lesion. The second category, an undisplaced posterior lesion, combined or not combined with an anterior lesion. And the third and the fourth category are displaced lesions. The third category, unilateral, and the fourth category, bilateral posterior lesions, as you have seen in the previous examples already. The question then comes up, should we operate on these frail and old patients? And when do we operate? How do we operate? And which technique should we choose? This is a publication that we published in an Indian journal. You see the different authors here. And here you see the organigram or the algorithm that we choose for the treatment of these patients. On the left side in blue, you have the stable lesions. Stable lesions after the evaluation in CT and conventional X-rays. And most of them do not have severe pain. They are able to walk, and after a good conservative treatment, they are able to be discharged from hospital. But that's not the majority. The majority lays here in the red group. Some of them come from the blue group because treatment was unsuccessful. But if you have unstable lesions, type 3 or type 4, then you should perform surgery immediately, or you should propose or try to convince the patient to perform surgery. And there we are sure that anterior fixation and posterior fixation is necessary. We looked back at 519 patients from our department with these types of lesion. And the type 2, which is the group with undisplaced posterior lesions, counted for 238 patients, which is about 50%, somewhat lower than 50%. This is a very important group, and there is still discussion in literature on how to treat these patients. You see here in this retrospective study, we treated 78 patients conservatively and only 21 patients operatively. The median length of hospital stay in this whole group was 10 days, was a 1-year mortality of 14.2%. And you see here with these 2 parameters, there is a significant reduction in quality of life and mobility. But if we now compare the non-operative group with the operative group, You see, this is a minority. At that time, this was a retrospective study. We found a significant difference in mortality after 1 year, 2 years, and 5 years in the operative versus the conservative group. That means that the operative group has a better survival after their surgical treatment. If we look now at the patients with type 3 and type 4 in this large group of 519 patients, this is about 1/4 of our patients. There we only had 30% conservative treatment and about 70% operative treatment. The median length of hospital stay was longer than in the group with FFP2 lesions. The 1-year mortality was similar, 15%, but there was also a significant reduction in the quality of life and in the mobility of these patients. But again, and here you see the Kaplan-Meier curve. After 1 year, 2 years, and 5 years, we found a better survival of the operatively treated patients. So in both groups, the unstable lesions and the stable lesions, FFP2 patients with stable lesions, undisplaced posterior lesions, both profit from a surgical treatment. In Mainz, we favorized in this retrospective time, this is between 2010 and 2020, we favorized a transsacral implant, transsacral bar. You see here, this is the corridor of S1 in the lateral view, and the bar is this black spot. It is about 6 millimeters of diameter and had a thread from the beginning to the end. On both sides, there are washers and nuts, and you see here that this washer is pushing against the lateral cortex of the posterior ilium on both sides, and the bar is going through the corridor of S1. An example here is a 68-year-old female with a FFP type 2C lesion. You see the complete fracture here, an incomplete fracture there. It was a conservative treatment which was unsuccessful. And here you see the pelvic AP inlet and outlet view after the surgery. You see the position of the transsacral bar, an additional iliosacral screw, and a retrograde transpubic screw to bridge the fracture in the front. Here in the inlet view, you very nicely see that this transsacral bar can, or the nuts on the transsacral bar can put some compression on the posterior ilium, posterior sacrum. Another example, a 77-year-old female with an FFP type 3 lesion, so a displaced lesion. You see a large displacement and instability at the symphysis pubis, and you see a older fracture on the left sacral ala in this patient. So she had 2 months conservative treatment without success. And here we were obliged to perform a double plate osteosynthesis in the front, but you should focus on the back, and you see the position of the sacral bar through this corridor, going from left to right with nuts and a washer that increases the stability. We look back at 85 patients that underwent such a procedure. We needed a revision in 13 of them, which is 15%. This is also retrospective study, so in our view, a too high number. The 1-year mortality, nevertheless, was below 10%, and this was in the only group with such low mortality in our retrospect study. Just go back for a moment. And after 3 years of follow-up, 85% of these patients lived at home, and 82% walked with or without a walking aid. So if you look at these patients that had this type of fixation, you can say low mortality rate and very good mobility and independency after 3 years, most of them living at home. Nevertheless, a too high operative revision rate. We looked at this space that was available for transsacral implants to treat this fracture with this transsacral bar. And again, Daniel Wagner, that this three-dimensional study on 92 Europeans looked here at 156 individuals and looked at the CT scan and calculated if a transsacral corridor was available in these patients. And you see here the results, which are very striking. 51% of the pelvis accommodated a transsacral implant with a safe zone above, below, in front and back of the implant. 22% did not offer enough space in S1 for an implant, even when ignoring the safe zone. And in S2, there could be a corridor in most of the cases, but there the diameter is smaller and not all of the fractures are suitable for this type of stabilization because most of the fractures are situated above S2. But here, so it's very striking that we are not able to implant a straight transsacral bar in about half of our patients when we ignore the safe zone in about 1/4 of our patients. The same we did with the anterior pelvis. Mrs. Charlotte Arendt of our group looked at the pubic corridor for implantation of a straight cancellous screw, as I have showed you in some of the examples before. So she calculated this corridor in 150 uninjured pelvis, which means 300 corridors because you have 2 corridors on each pelvis. And also here you see here the pelvic, radiographic reconstructions of a patient with 2 retrograde transpubic screws. And you see here that a transpubic corridor with a diameter of 7.5 millimeter was available in 185 of 300 investigated superior pubic rami. Also here, we see that in a large minority of our patients, it is impossible to insert a straight long implant through this transpubic corridor. So that means that a minority of our patients, a large minority, will not fit for a straight implant in the back and a straight implant in the front. And that, I think, is the place where Curvafix comes and has a big advantage. It's the only implant that follows the natural curvature of the pelvis. You see here, I think all of you will know that the implant just takes the curve, the natural curve of the posterior and also the anterior pelvis. And I think that this is a very good alternative to our straight implants that we used in our retrospective time period between 2010 and 2020. And I would be happy that also in Europe, this implant becomes available for stabilization of fragility fractures of the pelvis as well in the posterior as in the anterior curve. This is my last slide. It shows the incidence or the absolute numbers of pelvic fractures in the United States in 2019, together with hip fractures. You see the hip fractures are in number much higher than the pelvic fractures. But if you look at the geriatric population here, then you see that the pelvic fractures are treated operatively in 95% of the cases, and the geriatric fractures, pelvic fractures, are only treated in 5% of the cases operatively. So 95% of the hip fractures are treated operatively. Only 5% of the pelvic fractures until now are treated operatively. And these are numbers of 2019. So I would like to conclude that here, especially for the pelvic fractures in the elderly, there is still room for further gains. Thank you very much for your attention.
Good evening, everyone, and thank you for joining us. I'm going to ask Mike, Brett, James, and Steve to turn their cameras on. We have several questions that have come up through the queue. Those are all really great presentations, and I thank you for doing those. I think I'm really curious, especially after hearing Paul's presentation on the fragility fractures of the pelvic ring. How aggressive are each of you in, and I know, Brett, you outlined some criteria that you use, but I'm curious to hear from the panel how aggressive you are in fixing some of these fragility fractures that we're seeing that seem to be increasing in number. And maybe Mike or Jim, if you want to start off.
Yeah, so I've, for the last 10 years or so, been fairly aggressive in fixing these. If you use a LC classification with these, if you have an LC1 comes in that we typically treat non-operatively, if they can't get up and mobilize within the hospital after about 2 to 3 days, I'm taking them to the OR and fixing them. I mean, old people need to get up and move.
Okay, James, same thing.
Yeah, I agree. Not only just getting up and mobilizing with PT, but if they have significant pain in bed with log rolling, repositioning, getting onto a bedpan, et cetera, I mean, those are all, physical signs for me to push me more towards surgical stabilization to aid in that.
And Brett, is your protocol then 3 sessions with PT, and if fails, then you're operating on them?
Yeah, that outlines it well.
And then what's your post-operative weight bearing protocol on either Curvafix if you've been using it more, or traditional screws? Are you changing your post-op protocol for these patients?
For me, they're all weight bearing is tolerated. Yeah.
All right, weight bearing is tolerated, Brett. Mike, weight bearing is tolerated, and James, weight bearing is tolerated.
Same. Try to fix them so they can be fully weight bearing.
Okay, so you're pretty aggressive about both posterior and anterior ring fixation if you have to do it.
Both, yeah.
Okay, all right, great. Brett, how do you think an implant like this can maybe help us manage things like sacral U or sacral H type fractures? Do you think this changes the paradigm a little bit away from lumbopelvic or modifies it in some way?
I'll tell you that I don't get a lot of lumbopelvic fixation for patients. Not that I don't understand the concept. I mean, I don't do it very often or do it with my spine partners very often, probably once or twice a year. And so I try to primarily use sacral fixation and complete the ring from a fixation standpoint. And so really, I can understand in geriatric fractures that I think it's less common to need lumbopelvic fixation, but usually it's those high energy vertical shear patterns with L5 facet S1 involvement facet, L5 facet involvement, maybe even a little bit higher. So those would be the times. I don't always use sacral comminution as an indication for lumbopelvic fixation. But I think it can be, I think this is more beneficial in older patients, at least for the patients that I treat, and patients with dysmorphic sacrum, like James mentioned. I think this is where this implant really changes it. And I think it also can make, with the smaller version coming out, with the 7.5 version coming out, I think it'll increase the ability to do anterior pelvic ring fixation, make it more efficient or easier, I guess.
Well, and since you brought it up, and Steve, maybe you can comment on, there were some questions around the 7.5 millimeter implant. And I think we heard from a couple of our presenters today about the challenges of putting the larger implant in the anterior ring. Although I think with some careful planning, you can do that. I just did that the other day. But it is more challenging with a larger implant. So what are the mechanics around the smaller implant compared to the larger implant, Steve?
Sure. Well, I want to say thank you first of all, everybody, for contributing on the panel, and thank you for everybody listening. And we're just delighted to be working with you all and on this problem. So the 7.5 actually came about because we got surgeon feedback that the 9.5 was too large in a number of cases. So for us, taking something that's 9.5 and making it 7.5, of course, is more challenging mechanically. But the good news is we've got some really creative engineers, and we've learned a lot over the last 6 or 7 years that we've been doing this. So all those innovations have gone into the 7.5, and we've done extensive testing to ASTM standards. In fact, both for straight screws and for rods, because this is essentially an intermedullary rod. And what we've been able to do is a 7.5 in and of itself mechanically is as strong or stronger than our original implant. But our guidance to you all is it's not just the strength of the implant, it's the size of the implant and the curve of the implant. So use a large one when you can, but the smaller one's actually very strong, and it was straightforward getting it through FDA. We got it through quicker than we thought, just because the test data was as strong or stronger than the original. So I don't think the strength of that smaller one is going to be an issue at all. I think it's going to work really well, and we're looking forward to getting out to the field very soon.
Thanks, Steve. James, I think, and the panel, anybody really on the panel is going to direct it to James, but any of you can answer this. Obviously this is a tool in your toolbox. And I don't think any of us are going to sit here and say this is going to replace traditional cannulated screws. But when you have this tool in your toolbox, what's your philosophy or your approach to pelvic ring injuries? When do you think about taking this out? When and how does this maybe affect your decision making? And James, after you answer, I'm going to go to Mike, and then Mike from Mike to Brett. In terms of how do you look at this as a tool that you utilize?
So, in my training, we were pretty aggressive in treating pelvic ring injuries. I think more often than not, if the injury looks potentially unstable, or the patient is giving you, physical signs, namely pain of instability, we take them for an EUA, and we, do an inlet, and we stress the ring. And usually I'm doing anterior and posterior fixation. I think, the power of this implant is if you have a potentially smaller patient that has a dysmorph, you could fill the upper sacral segment corridor with this, rigid implant, go across and really give strong fixation. And then usually I'm supplementing the anterior ring with something as well. I haven't been able to use the smaller implant yet. I'm very excited to try it. I think that it will help significantly navigating the anterior pelvic ring and filling the corridor. And then to answer your other question, I generally don't take out any posterior ring fixation unless it's in a child.
Mike, what about you? Where do you see, what's your philosophy now that you have this in your toolbox to approach these injuries or pelvic rings in general?
So for me, this has played a bigger role in the older osteoporotic insufficiency type fracture patients than it has in the younger high energy trauma. I've used it in some high energy trauma places, but I think it's most beneficial when you have a dysmorphic corridor like James showed. Then I think there is some benefit to it in the adult type population. The only thing that I think it becomes a real benefit to in a lot of these fractures that we can treat with traditional implants, if we can prove that there's a difference in the ability to make them weight bearing as tolerated immediately for some of these injuries that we're now, still non-weight bearing them for a period of time. In the insufficiency fractures, I think it gives you a lot of advantages. One, it gives you a tactile sensation of putting it across that is not present in putting a wire across. However you want to put that straight wire across, you get more of a tactile feel with this, and can can get around some of these tough corridors when you have deformity and some of this poor bone than what I've struggled with before with it. And I also think there's something to the resistance of moment of rotation with the curved design of the implant, especially around your upper sacral segment, where you're always going to have an anterior moment on that point in your posterior pelvis, that I think there's something to the moment of rotation resistance that you get from a curved implant, because now you're feeling or getting a 3-point contact going through on cortical bone, and you're not. I think you're going to have less failure and dependence upon your bone implant interface, which is where we always fail in osteoporotic bone.
Okay. Brett.
I think those are great comments. And I like the idea of the 3-point bending, at the added stability due to that. And I think that is, that would be something that would maybe change in higher energy, younger patients. Do you let them weight bear earlier? And I think it's a good kind of thing to investigate for sure. The one thing that I'm going a little down a rabbit hole, but one thing that I was really worried about when I started using it in the insufficiency fractures is because there's fewer threads, and we always use fully threaded implants for these poor bone quality patients, is that I really thought I would see them start to back out. And that's kind of one of the things that I've been impressed with. And it probably is related to that 3-point bending stability, that they don't back out without having so many threads. At least that's my perception. And so I do take implants out of younger patients in the posterior pelvic ring, and I have, that's something that I would consider doing, and if I used it in higher energy younger patients. But I think it is something that can allow for potentially, comminuted sacral fractures to. I'm pretty aggressive and let them weight bear at 6 weeks, but one thing that would be interesting is how more stable they feel with, say, 2 larger implants with 3-point bending versus, smaller diameter straight implants. I was just thinking of some things to investigate in the future that may be interesting.
One thing with taking this out is you have to make. I have taken one out, but you have to make sure you get it unlocked.
Yeah.
That way you're not trying to rotate that curved implant, because you can cause a lot of problems then. So you have to make sure it gets unlocked before you try to take it out.
Good point. I grew up in a philosophy where, if you had anterior ring injury, you could overfix the back, and that would provide stability to the front. The front wasn't as important as the back. I think that, that is a function of having good corridors in the back. It's also a function of some of the challenges of putting anterior ring fixation in. I know that I've been in the operating room and you struggle to get that starting point. I think to myself, it is way easier to put screws in the back of the pelvic ring than it is the front of the pelvic ring sometimes. And I think Paul's data that he shared and showed us about the anterior ring being very undulating, I think is very appropriate sometimes. And I've bailed from, a 4-5 or 5-5 screw down to a 3-5 screw just to get something across the anterior ring. My question for you guys is, do you see an opportunity potentially where we can start to not overfix the back, but if we can fix the front and the back, it would allow us to not maybe put multiple points of fixation in the upper sacral, in the posterior sacral segments, but rather maybe a simpler fixation in the back because you're augmenting the front as well? Do you see there are opportunities there or not really?
Yeah, I think that's what the biomechanics showed. We did a biomechanics paper, like whatever you do in the front matters more than what you do in the back. And so I really have, since we did that, have really gone for fixing the full ring, anterior and posterior. And I think it does offload the posterior implants, and makes it less necessary unless there's a specific purpose to really load up the back, like if there's a lot of comminution or whatever. But I really have kind of gone more towards fixing the full ring.
Great.
I like anterior fixation. People just seem to be more comfortable quicker with it than even just like moving in bed or transferring things like that. They seem to be more comfortable if you fix the front.
Yeah, I agree.
I totally agree with
You
that.
don't need as much in the back then either.
And yeah, I'm always doing anterior fixation, but I like to kind of just see. I always start with the back and then I'll stress it again. And invariably, there's always a little bit of extra deformity that you'll see, and then you stabilize it and it doesn't move.
Well, I want to thank all our panelists for being here. Steve, I've got one question for you. It came up in the chat room, and that is, when is the 7.5 going to be out in people's hands?
We will have it out early next year. So we've got the first lot. It's kind of on its way to packaging, and it'll be very soon. So we look forward to working with you all with the new implant in the clinic and continuing this forward. And thanks so much.
All right. Thanks, everyone. Have a great evening. Thanks again for your time. Great presentations, and really looking forward to changing the way we look at pelvic rings. Have a good night, everybody.
Thanks,
Thank you.
guys.
Good evening. Thanks.
Thank you to all of our speakers for an excellent program. And most importantly, thank you to all of our attendees for participating in this evening's program. On behalf of Curvafix and today's panel of experts, be safe and stay well.